Thank you to the organisers for inviting me to speak today. As you know, there's been a plethora of papers that came out in 2015, and there's absolutely no way I can touch even a tenth of them in the 20 minutes that I have. So I've just chosen papers that I have found to be clinically relevant to my daily practice as a medical microbiologist. I've also borrowed slides from a few speakers at TIMM, which touched a chord with me in that I see these patients, and they're the patients that I feel personally at Barts Health we don't deal with as adequately as we could or should. I'm also going to talk briefly about combination treatment. I've always believed for a long time after working with Chris Kibler that there is a role in combination treatment, but there isn't many papers out there to support that, and also a few words on the latest drug on the market. So I'll start with the diagnostics. And Peter Donnelly gave a presentation at TIMM on the soon-to-be published EORTC MSG updated guidelines for invasive fungal infections. Most of you will be aware that these guidelines first came out in 2002, and the purpose of it was not for use in hospitals or in the clinical setting, but for clinical trials to better define invasive fungal infections. These guidelines were updated in 2008, and they were much improved, but there were still a few problems with those. Lewis White this morning focused on the fact that molecular diagnostics were not included, and in the new revised versions they will be, which is timely. So what are a few other issues from the 2008 guidelines? As we heard yesterday morning, we had presentations on antifungal stewardship, not just one, but from 3 different speakers, which included intensive care, pediatrics, and also in hematological oncology. So it's evident that antifungal stewardship is variable in these different groups, and I'm glad that the guidelines are now taking into account that different groups have to have different guidelines. There's also been a lot of questions about the various diagnostic tests available, the use of galactomannan, beta-D-glucan, and molecular methods, and how these may vary in different patient populations. As Adelia said yesterday, in children, 5 mL of blood is a lot of blood, and these are things that have been considered in the new guidelines. There's also been very poor definitions or inadequate definitions for conditions such as pneumocystosis, cryptococcosis, and anemic mycosis. So, all the things I've just mentioned as issues in the 2008 guidelines have been addressed separately by multiple working groups comprising experts. And for diagnosis, they've looked at imaging, galactomannan, beta-D-glucan, PCR, and tissue diagnosis all separately. And I think these will be a much better set of standards than there has been, and hopefully, although they're still for clinical trials, they may be valuable in clinical practice. Now, as Samir is the host of this meeting, I thought I should start my first review of a paper by Gemma Johnson at the back and Samir from this unit, looking at the use of the triple test approach, combining PCR, galactomannan, and lateral flow in the hematological oncology setting and transplant patients. There were 25 BALs included in this study, which was published in the Journal of Clinical Microbiology last year, with paired blood samples. In 5 of these 25 samples, they were positive by the triple test, which is the PCR, as I've talked about already, and the correlation in blood was not as good. For 3 of the 5 BAL positive samples were positive by PCR in serum or blood, and 4 of the 5 PCR positive samples in the BAL were negative by galactomannan and lateral flow. The time from the antifungal drug to the BAL being taken was a median of 6 days. So you can see that the pickup rate was still quite good despite antifungal therapy. We use fluconazole here at Barts as our antifungal prophylaxis rather than an azole active antifungal. And culture and CALC4 was negative in all these patients. So 20 of the samples were PCR negative. There was no samples that were positive amongst the negatives for Gallagher and lateral flow, but 2 had false positive Gallagher-Mannans and 1 had a false positive lateral flow. The corresponding blood or serum was negative in all these 20 patients. I'm going to skip that. So, this paper was analyzed using the kappa coefficient, which is a statistical measure for inter-rater variability. And as you can see, there was almost perfect agreement between the PCR and the lateral flow. To summarize then, the triple test approach, as Martin Honeygel has also highlighted previously, is very useful and effective in BAL. It is a less sensitive test in serum. This is Martin Honeygel's paper, but I'm going to skip it. I couldn't delete it because I'd sent it through as PDFs. But again, it shows that the lateral flow in BAL is a fast test with moderate sensitivity, so between 70 to 80%. Skip that. Okay. Just to talk briefly about this bedside test that has been very useful. There was a study done in Uganda, and Sheila mentioned it as a test for quality assurance, on 207 HIV-infected adults, and it's a finger prick test, and looking at whole blood plasma or serum and CSF, and there was 100% agreement between these different samples, which shows that it is a reliable point-of-care test. And personally, I think that there might be some use of it in East London. I think they're now evaluating it in A&E at the Royal London. So on then to a few clinical slides. I'm going to start off with cryptococcal meningitis. I don't know if Chris is here, but he gave us a difficult question last night. I was quite upset because our group got a 0, despite the fact that I've worked with cryptococcal patients for a long time. So this study showed that it looked at the use of early antiretroviral therapy and survival in patients with cryptococcal meningitis. And it showed that there was an increased mortality associated with early treatment. And a lot of this was thought to be immunologically mediated, not the immune reconstitution syndrome, but some other mechanism, and that deferring antiretroviral therapy until 5 weeks after treatment will improve survival. I thought that was quite an interesting paper, and it supports what Chris was saying last night. So then on to combination therapy. This paper by Kieran Ma's group was published last year, and it looked at combination of voriconazole and anidilafungin versus voriconazole and placebo. And I think there were about 454 patients randomized to different groups. And basically, it showed both in the primary analysis at 6 weeks and the secondary analysis at 12 weeks that the combination of voriconazole and anidilafungin was associated with this non-significant but clinically meaningful survival benefit. And I think it's sad that it didn't reach, it didn't have enough power, but I think, and I don't think there'll be any further studies looking at this in as much detail, but I still think these results are promising, and that we could use combination therapy in patients that are failing on monotherapy. So just to finish off this section, as we all know, azole resistance is increasing worldwide, and this study by Mike and Arundup's group demonstrates that quite clearly. It was a multi-center study of 22 centers, and it showed an overall prevalence of azole resistance of 3.2%, and in invasive aspergillosis, it showed a prevalence of 5.1%, which I think is quite significant. So then on to chronic pulmonary aspergillosis. These are all David's slides, and he might be using them himself later. So these guidelines were published in the European Respiratory Journal at the end of last year, and David was on the working group. Just a few brief words on the different clinical entities associated with chronic pulmonary aspergillosis. I think personally in our trust there hasn't been as much of an understanding of or recognition of these different phenotypes. So the first one is the single aspergilloma, which is classically located in the apex of the lung. You then get the aspergillus nodule, which is not as well defined in the literature. And patients in that group classically present with cough, shortness of breath, hemoptysis, or loss of weight. And it is important in that group with the aspergillus nodule to do a lung biopsy because you need to exclude cancer, cryptococcal disease, or non-tuberculous mycobacterium. The most commonest presentation of chronic pulmonary aspergillosis is chronic cavitary pulmonary aspergillosis. Most of these patients are Aspergillus IgG positive, and over many years, the patients go on to develop chronic fibrosing pulmonary aspergillosis. The important thing about chronic cavitary disease is that you need to treat at an early stage. If you wait for the fungal ball to present, it may be too late. All these disease entities that I've just talked about occur in non-immunocompromised patients. Moving on then to the spectrum on the left, on the right, you see the categories that affect immunocompromised patients, which is the subacute invasive aspergillosis, which is very like invasive aspergillosis, or chronic necrotizing pulmonary aspergillosis. So patients with chronic pulmonary aspergillosis have a lot of underlying conditions. You can see the multiple studies there, and the main ones being classical TB, COPD or emphysema, pneumonia, and pneumothorax, but there's a whole raft of other conditions. This slide is from Malcolm, and it just shows the whole spectrum of the diagnosis of chronic pulmonary infections. And the various different diagnostic tests, starting with Aspergillus antigen for invasive aspergillosis and Aspergillus-specific IgG for chronic pulmonary aspergillosis, and the use of Aspergillus IgE, which can be very helpful in patients with asthma and other allergic conditions. The use of IgM and IgA is of no benefit in this group of patients. So just to mention that, we recently had a patient with chronic pulmonary aspergillosis, well, it was last year in our ITU, and we didn't actually look for IgG. We did the other range of tests, and I think it might be useful to go back and look at this as well. Basically, with this test, the levels respond to treatment, so you get falling levels, and you can use it to monitor response to therapy. In this particular patient that we had, we did Aspergillus antigen, which was negative, and we did IgE, which was again negative, but going forward, I think we'll look at this. There's 4 commercial platforms, I think, that they've looked at in Manchester. It might be worth getting one of them in. So then, oral triazole therapy is recommended for treatment, itraconazole, voriconazole, or posaconazole. None of the studies that have looked at this has been powerful enough or large enough, so the quality of evidence is only 2, but this is what the recommendations are. And I just want to highlight that I think therapeutic drug monitoring, that a lot of speakers have talked about it, and I think it's really important. In particular, patients with from Northeast Asian descent who may be slow metabolizers can have accumulation of the drug if you don't do monitoring, and they can get toxicity. We had a patient last year from China who did not have TDM. He was on ITU, and he got severe liver and bone marrow toxicity. Despite being admitted as an emergency by the liver doctors, it took 3 months for his liver function and bone marrow function to recover, which is quite severe. So then, to conclude on this section, the evidence base for using radiology and Aspergillus antibody is very strong. The radiology signs should be present for about 3 months. There is a lot of evidence for using IgE. And just to mention that immune deficits are very common in this group of patients, and that's why you recommend long-term therapy. The immune deficits that you see in these patients are not the classical ones affecting cell-mediated or T-cell deficiency, but they're the ones that involve multigenic factors such as gamma interferon, interleukin-12, or mannose-binding lectin deficiencies. So it's not something you would see straight off. In patients with fungal balls, azole resistance is now a major problem. As I've alluded to, in Barts Health, we have a lot of intensive care units. At this site, we have the hem-onc and the cardiothoracic intensive care. And we have 2 district general hospitals in our repertoire with intensive cares. And at the Royal London Hospital site, we have a general ITU, which is a major trauma center. In all these ITUs, we have seen invasive aspergillosis. Increasingly, Aspergillus is presenting not in the high-risk groups, which is the hematological malignancy group, but it's being found in the moderate risk group. And multiple publications have now found it to be increasing in non-traditional groups, and there have been a lot of papers looking at Aspergillus in COPD patients. We had 3 patients or 4 patients last year in our ITU at the Royal London from the respiratory team, and their Aspergillus was not managed properly. So this 3 pie charts show that changing epidemiology. Back in 2000, there was a paper by Tom Patterson which showed 67% of cases was in hematological malignancy or bone marrow transplant patients. A publication about 5 years later showed it was still a preponderance in hem-onc patients, but a more recent study showed that actually it's in non-traditional groups, and a lot of them had COPD. And I think we need to be aware of that in all our intensive care units. So what is the incidence of Aspergillus in COPD? 2 studies, one in Canada and one in Spain, had a similar occurrence of about 3.4%. The outcome in all patients with COPD and Aspergillus who are in intensive care is 100%, so it's pretty high. And which variables then you predict invasive aspergillosis? And the biggest variable in this Spanish study was in patients who are receiving high-dose steroids, which is probably true actually, because a lot of patients who go to ITU do receive high-dose steroids. I missed off the word galactomannan in this. This is galactomannan serum determination in COPD patients, and the results have been quite variable. I think the key message from this slide is that galactomannan sensitivity in non-neutropenic patients is low. It's on average about 50%, but the specificity is much higher. Beta-D-glucan probably shows the most promise in the intensive care setting, but there isn't that much available in the literature, and this is probably an area that a bit more work could be done in the next few years. PCR has a role in intensive care when you look at lower respiratory tract samples, and you can see from these few studies that positive PCR and positive galactomannan confirms aspergillosis, and a negative PCR and a negative galactomannan excludes aspergillosis. And that's what we found last year when we had those patients in intensive care. So then, what do you use to treat COPD patients? The literature shows that there's poor response when you use amphotericin B in this group, and therefore voriconazole is the recommended primary treatment. It's an A1 recommendation. Again, looking at drug levels is important. I'm not going to talk about the slide because Patricia Munoz talked about it yesterday. Then to my final talk, which is on isavuconazole. Chris talked about it in detail last night, probably a lot more detail than I'm going to give you today. But basically, this was a study that was done to look at the primary treatment of suspected invasive mold infections. It was a 6-year study which recruited 527 patients randomized to isavuconazole or voriconazole. And in a nutshell, the trial found that isavuconazole was non-inferior to voriconazole. It was also well tolerated with fewer adverse events, and this was statistically significant. Thank you.